incredibly... Shall we?
I know my throat is going to choke, so...
Good afternoon, everybody. We'll push on. A couple of announcements to make. We're excited to have a record number of delegates gathered in Glasgow. The slide that comes up between presentations is out of date. That says 1,400 delegates. So far, we've got 1,550, but there seem to be a lot of on-site registrations as well, so we're hoping to push that up to 1,600 people by the end of the conference. But that demands more from all of us in terms of the delegates, the organisers, support staff, catering, etc. So please be patient if you find you're queuing or not getting to something as quickly as you'd like. Because we're so busy, timekeeping is important. We've included 5-minute walking time between sessions in the programme, but please be in time for your session, especially if you have to upload your presentation. Please also be in time for coffee and lunch breaks as well, because with so many people around, we want to try and get everybody served and back to their sessions on time. Finally, I'm pleased to announce that there'll be a film festival, which will be held here in the Clyde Auditorium at 10:40 a.m. tomorrow, where there'll be 5 films in the theme Understanding Health Inequalities in Glasgow. I dug my grave earlier. I didn't realize when I said that Johann Machenbach needs no introduction. I now have to say it for all of the people I'm going to introduce. But of course, you all know Martin McKee, who's going to moderate the next session. He's Professor of European Public Health at the London School of Hygiene and Tropical Medicine and Founding Director of the European Centre on Health of Societies in Transition. He's also the new President of EUFA. Martin.
Okay, thank you, Alistair. Thank you very much, and thank you all for staying to this stage in the evening. And we will be looking in this session at inequalities in the population, large-scale interventions. And we have 2 initial speakers, and then we're going to change format. So the first speaker I'm delighted to introduce is Dr. Margaret McCartney, and those of you who read the British Medical Journal will be very familiar with her work as a regular columnist. And if you haven't already bought her book, The Patient Paradox, I can highly recommend it. In fact, as some of you know, I've been recommending it for a very long time. I get no cut out of that whatsoever, but it's thoroughly worth reading. And Margaret is going to talk to us about what large-scale interventions work. Please.
Okay, thank you very much for having me. I'm going to try and condense this down into about 11.5 minutes. I'm also going to try and speak slowly, and being from Glasgow, I don't find that easy, so call me out if I get it wrong. I'm a general practitioner in Glasgow, and I've been working here for the last decade. And I'm extremely concerned about health inequalities in Glasgow, and you're all highly aware of that yourselves. My declarations of interest are available at whopagethisdoctor.org. I'd urge you all to sign up. Conflicts of interest are a big unspoken problem in much of medicine, and we need to get our financial conflicts out there for our patients to criticise us before they take our advice. Okay, so modern public health is a big success story, and congratulations to you on that. Vaccination is one of the biggest success stories I think that we have to offer. Fantastic, but we've got problems, I think, in the way that population interventions are being targeted at individuals. Certainly in my day-to-day work, I have huge problems with what we're doing. So we have an awful lot of screening, and we have different types of screening. We have screening that's been approved of by the UK National Screening Committee, which is like the NICE for screening, as you know. It looks at evidence and it tries to make evidence-based decisions. But we've also had a huge amount of screening which has been pushed upon us by the General Practitioner's Contract, which is basically all about box ticking on a screen in order to satisfy Jeremy Hunt that we're not in fact cruising in our day-to-day work and that we're, in his eyes, taking patient care seriously. In my opinion, the GP contract has been one of the biggest problems that I have to face in my day-to-day work. And what we're really dealing with now is a whole science or not of risk factorology, where we're risk profiling all of our patients, giving them numbers or percentages about risk in the next 5 or 10 years, offering them interventions that may or may not work, all medical interventions, statins, blood pressure tablets in the main, and asking them to do something about their risk. This has been a huge change in work, something completely different, and I think we have scarcely begun to give patients good enough information about how to make sensible, informed choices about what they're being offered. And it's also a very individual offer. These are targeted at individual patients, individual people being asked to make individual choices, not really what true public health is all about. And this has led us, of course, to statination, prospect where most of the country of our over 50s are on a statin for the very long term. Is that really good public health? You all know this graph by my brother. Poor people die younger, in Glasgow in particular. This is the problem. How are we going to tackle it? It's the people who are dying younger that we need to protect here. The rich can look after themselves. When the GP contract was announced, the Lancet came on and said, or not the GP contract, when the Department of Health came on to criticise what GPs were doing, the Lancet came out to say that GPs themselves were lacking in simple and proven interventions to help prolong people's lives. And they were really talking about implemented evenly across the population would go a long way to reduce inequalities in health, notably smoking cessation and the treatment of high blood pressure and raised cholesterol. And that was what the Lancet saw as the way to reduce health inequalities. But there are enormous risks in doing this. It's targeting individuals rather than populations, remember. The other way that the government is trying to do this, again, reducing risk of people at biggest risk of inequality, is through NHS health checks, which have not been approved by the UK National Screening Committee. It involves everyone over 40 having a risk assessment done of their vascular risk, and it's being advertised as something that will help you live longer and see your grandchildren, where there is no evidence that that is in fact the case. There's also been a huge push towards screening for diabetes. Diabetes UK, one of the charities in the UK interested in promoting diabetes screening, really using incredibly emotive adverts around Glasgow last year. Check your risk of type 2 diabetes or risk stroke and amputation. That was the choices that were being offered. Check your risk of diabetes, if not for you or your family. And Tesco, that well-known healthy purveyor supermarket, telling us that 1 in 7 people are at risk of developing diabetes. Check your risk today in one of their pharmacies. So this huge push towards screening for diabetes. And just to remind you just what happens to our risk calculators, this is from QRisk, and it's an assessment of how well it performs in real life. So your grey area is the population, your yellow area is the people who develop cardiovascular disease, and the pink box is the people who are identified as high risk by QRisk2. They do not match. So we identify people that we think are going to have a problem when we don't, and we miss people who do have a problem when we don't think they will. So it's highly inaccurate. I mean, it's really a bit like a dartboard. It's not a very good way of identifying people at highest risk. And the other problem is, if you're trying to identify targets to reduce inequalities at individuals, you have to think, what about concordance? We know that about half of people do not take their medication as prescribed. If you're offering treatment for blood pressure or cholesterol in the long term to reduce health inequalities, can you be sure that will actually get to the people who are in most of need of a benefit? And the problem is that we can't. Now, there's a really good meta-analysis that was published in the BMJ a few years ago. And what they did was they looked at how well people adhered to medication and then looked at their mortality rate. And they found that people who were high adherers to medication, who took their medication as prescribed, did not die as often or die as young. But the problem is that effect held true even if they were taking a placebo. So it made no difference whether the drug was active or not. If you took your medication regularly, that was a sign of health. So you're targeting your interventions of blood pressure medications and statins at people who are already most likely to be healthy in the first place. You're not getting your intervention to the people who are going to die younger. This is not a good intervention to reduce inequalities. And we know that screening for diabetes does not work. There's been a big randomised controlled trial done in England proving it doesn't work. So why can't we move on from that and say, we've tried this, it doesn't work, let's do something better. We seem stuck in the same cycle of the political imperative to keep screening and doing health checks is damaging people because it's taking resources away from the people who need it the most. The bigger problem, again with screening, is that when we target populations rather than individuals, we lose informed consent. And when people are invited to breast cancer screening in the UK, they're given standard forms. They do not speak to someone to decide whether this is an intervention they would want to have. And then again, we keep arguing how effective is breast cancer screening. We now think it's far less effective than it was, and we know the problems of overdiagnosis are relatively high. The Marmot review that was completed a couple of years ago now took 10,000 women over 20 years, found 681 cancers, 129 of these were overdiagnoses, cancers that would never have affected the woman's lifespan. She would have gone to her grave dying of something completely different and not knowing about it. But the problem is we don't know which are the overdiagnosed cancers and which are not, so all are treated. Marmot thought that in this group you could prevent 43 deaths from breast cancer, but this is not all-cause mortality. This is breast cancer mortality only. Marmot was quite clear that this gave a spurious impression of accuracy in his results. There's still a great deal of uncertainty over it. And for 638 cancers found at screening, there was no change to prognosis. These were cancers that would have been found and dealt with just the same whether they'd been screened or not. And this leads to the popularity paradox, where more women find more cancers at screening, whether overdiagnosis or not, and are then convinced that screening did save their life. And without fair information right at the very beginning, we cannot be sure that we're giving an intervention of value to that individual person. And again, we keep forgetting about the individual in the population. Where is the individual that was harmed? This is a woman talking about her diagnosis of breast cancer, which was DCIS, one of the cancers we're very uncertain about progression of. The reality of this diagnosis has been 2 wide excisions, 1 partial mutilation, mastectomy, 1 reconstruction, 5 weeks radiotherapy, a 60-mile round trip, and I had to pay to park. Chronic infection at the donor site, 1 nipple reconstruction, 7 general anaesthetics, and more than a year off work. Is really the best that we can do for population health, a large-scale intervention like breast screening? I really would want to see a return back to real public health, where the real firebrands have been always through medicine's history. Why are we bothering about, why are we at this stage of e-cigarettes and worrying about this when smoking cigarettes are still being sold in every supermarket and every high street? We've lost the battle. We have to, e-cigarettes should not be allowed. It's just, this is the new battle. We've seen TV adverts this week glamorising e-cigarettes. Public health activists should be right in there telling them it has to stop. Alcohol laws, why again are we holding back in Scotland with minimum prices? Mental health, huge inequalities to access good mental health care. We know that cognitive therapy works. People have to wait 18 or 20 weeks for CBT in Glasgow. This has to be unacceptable. If that was cancer, that would never have happened. What about the minimum wage, employment, making sure people have got a job to go to? What about adequate food, the food deserts that we have in some parts of Glasgow as well? Housing, I've been in houses in the past where you wouldn't have wanted an animal to live in, and we allowed that to happen. It's appalling. And the benefits, you look in the newspapers and you see people as benefit cheats, where we know that actually people are more likely not to get paid the benefits that they are entitled to, rather than making any fraudulent claims. This is the kind of public health that I think we need to have a real uprising of in the UK, and really start hitting inequalities and getting on top of this, because people are dying younger unnecessarily. To get there, and I think we can get there, I think we need to be really open about our conflicts of interest, especially political conflicts of interest. Why are so many people in government having interests in private health companies, for example? I think we have to be better at calling politicians out on bad policies, policies not based on evidence, policies that will harm us. I think we have to really use our generalists, our GPs that care about the same stuff as you do in public health, and really use our generalist skills to protect people against overdiagnosis and ensure that we're not creating a large pool of underdiagnosis in its wake. And we have to be better at sharing decisions, especially when it comes to interventions of lower unproven value. We have to be better at giving people fair data and allowing people to make really good, high-quality decisions. Thank you very much.
Okay, thank you very much indeed. Thank you. So I'm sure that's given you plenty of food for thought. And I'd like to move on to our next speaker. And as some of you will know, in the new UFA strategy, we have really tried to look at Europe in the world to have a much more global perspective on health. So it's a particular pleasure to be able to welcome a very good friend, Dr. Abdul Ghaffar, who is the Executive Director of the Alliance for Health Systems and Policy from Geneva, and from the World Health Organization. Please.
Thank you, Martin, and good evening, ladies and gentlemen. It's indeed my honor, pleasure, and pride to present few thoughts which would be more on research inequalities, but focusing only on southern institutions. So the outline is there's a historically 1090 gap and progress since 1990, because that was the first time this term was coined. Then geographical inequalities in research production, imbalanced priorities across different types of health research, and then few thoughts at the end. So in 1990, there was a commission which was called Commission on Health Research. They identified a 1090 gap, which strikingly demonstrated the inequality in research production at the global level, which meant 90% of health research funding went towards issues afflicting merely 10% of the global population. So, but there has been a significant progress since then, and this is the World Health Report 2013, which was on research. Overall, R&D investment has been growing rapidly in the low and middle income countries at 5% per year, faster than the GDP from 2000 to 2008. So that's a good news. And similarly, there has been increased institutional capacity to generate knowledge in Asia, Africa, and Latin America to carry out high-quality research. A rapid increase in the number of publications, increasing at an average of 9% per annum for middle-income countries and 4% per annum for low-income countries, as opposed to 2% per annum for high-income country over the period 2000 and 2009. And this just gives that numbers into a graphical, the high-income countries 2%, middle-income countries 9%, and low-income countries 4%. Similarly, the progress in the low and middle-income country authorship accounts for an increased share of internationally co-authored publications. For example, the share of Chinese co-authored papers in science and engineering increased from 5% in 2000 to 13% in 2010. And you can see that US, UK are almost same. Japan has declined, Russian Federation has declined, but China, Brazil, and India has gone up. What is the reason for persistent geographical inequalities? Scientific research continues to be highly geographically concentrated. 31 countries worldwide account for 97.5% of the most highly cited research papers, even today. India, with 16% of the global population, accounts for only 1.64% of health research citations accessible through PubMed in 2007. Africa produced less than 1% of global scientific publication output in 2004 and accounted for 0.6% of gross expenditure on research and development in 2000. For sub-Saharan Africa, 90% of the gross expenditure on research and development came from only South Africa. Other reasons for persistence: national level research is key. Conditions in other countries are likely to be different. Using imputed data or transferring learning to other settings is problematic. You know better than I know, because especially if the systems, policies, or implementation research, context matters a lot, and there are issues always when we need to transfer and use data. There are issues of generalizability, but that is not if it's policy and the systems research. In country, nationally performed research has been shown to alter clinical practices in low and middle income countries, and there's a significant evidence from India, Brazil, South Africa, even from Rwanda, Chile, Mexico. Countries in sub-Saharan Africa and former Soviet Union have lowest research output measures in terms of articles per 100,000 population. These are rather two regions where mortality has actually risen over past few decades. Continuing to making that argument, health research is a low priority for most governments, and the reasons are academic salaries are extremely low and prospects are often much better in the private sector. Research infrastructure is poor within institutions, often lacking access to latest journals and software. Institutional factors, lack of flexibility in hiring, remuneration, and promotion policies, difficulty in attracting talented researchers. I come from Pakistan, and last year we have a Lancet special issue on Pakistan, and I wrote a paper on medical education and research. And we were shocked that Pakistan Medical Research Council, they spent only $100,000 over the last 1 year on research, and 97% of their annual budget was only on the salaries and other expenditures. So they have a staff, but they don't have the money for either commissioning, conducting, or supporting research, and that's the case for many countries. So there are issues of linguistic barriers, overwhelming dominance of English in published literature. Around 96% of publications are in English. This negatively impacts researchers from Francophone and Lusophone countries. Also at national level, some countries do not recognize publication in English for promotions. Situation has aggravated by funders who need quick results and focus funding on areas with pre-existing research capacity. And we commission, conduct, and support research. And one of the issues we all want to ensure the quality, and for that we have a peer-reviewed, independent peer-review system. And that certainly helps those who has already the good capacity to write a good proposals. And that has to be sorted out at some point if we really want to strengthen the capacities in the low and middle income country, either through design, analyze, or dissemination the research evidence. How can we overcome the role of the governments? The governments should develop national health research strategies to identify what are their national research priorities and make a rational use of resources at the national level. And there is some evidence that wherever the countries have identified the priorities through a transparent and a systematic process, the demand for use of that research is higher than when the decisions are only made in the academic setting and the research institution. Increased financial contribution for health research. Countries in Africa need to meet target of 2% of health budget put forward by African Union and Commission on Health Research. And this has been repeated from 1990. The Commission on Health Research said countries should have it. Then region bodies like African Union, then Mexico Summit in 2004, then Bamako Forum in Mali in 2008. They have been always continuously reiterating this demand, and there's a World Health Assembly resolution that countries should allocate certain % of their health budget to research, and the funders should do it. It is not happening because research is still seen in many countries as compared to the programs a luxury or not very useful. But there are countries like Colombia who has started with innovative mechanisms to fund research and lottery revenue. Some people may disagree, is it an innovative system of making money, but it is working at least in Colombia. Prioritize the creation of national institutions for health research, and two good examples are National Center for Clinical Research in Rwanda and Public Health Foundation of India, which have primarily resources from the national governments, but they have been able to attract funding from the international bodies like the Wellcome Trust. So institutional reforms, including foreign collaboration to attract young, often foreign-trained researchers, as it has been done in Georgia, India through the Public Health Foundation, and in Chile. And that needs to be strengthened because I think there has been historically a collaboration north-south, but there are opportunities to collaborate between south-south, but international collaboration at the institutional level are important. Spurring the demand for health research by sensitizing policymakers to the importance of research in decision-making is a tricky business. It's not easy because policymakers have a different mindset and they are more sensitive to the time when they are in the power. They want to do the result. And sometimes research results take some time before they could be presented to either the policymakers or the decisions so which they can use. But this needs to be done and is happening in some countries. At the academic level, increased support for individual level training at master's and doctoral level in northern institutions to researchers from poor settings. There are some programs, but I think there is some sort of obligation at the northern institution to support those countries where they are doing a lot of research, getting data, analyzing, and publishing it. Contribute to strengthen research capacity at the organizational level. Individual level training in the absence of an enabling environment is likely to lead to brain drain. And I would be very honest with you, I was in a school of public health where out of 14, 12 of us were trained either at Hopkins, Harvard, or London School of Hygiene and Tropical Medicine. But the time came when the resources dried, all of us left. It's sad, but that's happened, it's a reality. Enable Southern researchers to access course modules, digital libraries, and software using tools such as cloud computing. Incentivize and recognize faculty efforts in capacity strengthening, because right now the incentives for the promotion are how much money you bring and how much publication you have. But capacity strengthening and impact or help to policy or decision making should be considered as one of the incentives. Funders, focus funding on capacity strengthening for research at both individual and organizational levels in countries with limited research capacity. In addition to supply side, provide funding for governments to build Ministry of Health capacity to demand and use research evidence. And there's a clear evidence nothing has changed unless Ministry of Health has become stronger in demanding and using evidence, and the examples are clear: Mexico, China, India, Chile, and there are many other. But if we don't have the capable, competent people sitting within the Ministry of Health, and that's a very different science, and there's a very different subject to strengthen the capacity in that regard. Enable researchers to submit research grant proposals in languages other than English to ensure a level playing field. And there is a priority imbalance because the health system research, there's a growing understanding of the limitations of the vertical programs and potential of these approaches to increase health inequalities. Importance of health system as global public goods. For example, Ebola crisis is essentially a failure of health system. I had a PhD from a very prestigious school of public health in 2000, and we were all part of Department of International Health, and I was in the health systems management department where I got my doctorate, but there was a department of infectious diseases. And we are always thought, I'm a health system expert and you are infectious disease expert. Ebola crisis has completely changed that reality. Infection controls are very much part of the health system. Good laboratory programs and the laboratory systems are important and significant components of the health system. So we need to change the mindset, and there's a new reality. How can we strengthen the health systems? Health system research has gained prominence over the past few years, and that has been establishment of global scientific society called Health System Global, but still it remains underfunded and understudied subject. Even in UK, 2004 and 5, only 4.8% of health research funding dedicated to health services research. In 2013, health services research was merely 6% of the NIH research funding portfolio of over USD 20 billion, comparable to the amount allocated for the hematology. Similar situation, low and middle income countries. 2010-2011, health system research accounted for 2.4% of research funding awarded by the Indian Council of Medical Research. And there's a recent publication from India which shows that only 5% of public health research articles in 2007 qualified as health policy and system research from whole of India. So how can we overcome these things? Development of research methods to address complex questions relevant to health policy and system research, because health policy and system research is multidisciplinary field where we need to combine not only use the epidemiology and statistics, but more so public policy, economics, social science, and combination of all these things. And as I said earlier, changes in academic incentive structure to take into account policy relevance and policy impact of research work, and development of short and long-term courses, and dissemination of the health policy and systems research. Funder needs to have a greater emphasis on flexible as opposed to project-specific funding to enable long-term trans and multidisciplinary research, ensuring reliable flow of funds for health policy and system research by setting aside a minimum percentage of health research funding for health policy and systems research. This is in fact a recommendation of the WHO strategy on health policy and system research, which was published in 2012 and launched in the Health System at the Health System Research Symposium in China. Allocating resources for health policy and system research as part of program implementation activities to enable the most efficient use of resources. And within WHO, we are promoting a concept which we're calling embedded research, which is the research to improve the performance, functioning, and responsiveness of the different programs at the implementation level. And the government also needs to put more money and strengthening the collaboration between the Ministry of Health and Health Policy and System Research institutions. The last slide, progress has been made since 1990. However, it has been uneven. As the World Health Report 2013 points out, research is not a prerogative of some countries, and it should be conducted and supported by each country. Emphasis must be on creation of national ownership for health research through building capacities at the individual, organizational, and systems level. Health policy and system research is a nascent, though underfunded, understudied field. Addressing this needs concerted action on the part of the health policy and system research community, governments, and funders. Thank you very much.
Thank you very much indeed. And both of the presentations really speak to different parts of the EUFA strategy. Margaret very helpfully took us through the importance of making sure that evidence underpins everything we do and challenging some of our preconceived notions of what the evidence said. And Dr. Ghaffar took us through the global dimension, and one of the things that we've been particularly concerned about in EUFA is the underrepresentation of European researchers in many of the global fora, like in Health Systems Global that was in Cape Town a few weeks ago, where we were relatively underrepresented. So I'm hoping that this will be the beginning of a much greater, we're all hoping it will be at the beginning of a much greater engagement with the global health agenda. Well, now we move on to something completely different, because what we are now going to do is to see an example of health services research, public health researchers speaking and presenting their case to a minister. We did try to get a government minister. And we looked around, we looked very hard, but they were all doing all sorts of other things. In the end, actually, we thought we could get something much, much better. So the alternative that we have, that will be known to all of you in Scotland and beyond, is that we have the former Chief Medical Officer of Scotland, in fact, one of the best Chief Medical Officers we have had in Europe for a very long time, and it's a personal pleasure to be able to welcome Professor Sir Harry Burns, who is going to take on the role of being a government minister. Harry. And then, if you'd like to join me over here, we have 4 of the leading researchers on health inequalities in Europe who are going to put their case to Harry. And he is then going to adopt the role of a minister and is going to challenge and question. They have to sell their ideas. So it's up to them, and we're going to see how the interchange goes. My role in this is to be the minister's permanent secretary. And that means essentially that I am aware that at the end of this plenary session, I have to whisk him off for a meeting with the Prime Minister, or, as we're in Scotland, the First Minister. Much more important. Or indeed the pub. And so I will be keeping him to time, and I'd like to invite our 4 eminent researchers to come up and join us. I think we're going to come up over here. And they really do need no introduction to this audience, Margaret Whitehead from the United Kingdom, Johannes Siegrist from Germany, Anton Kust from the Netherlands, and Carmi Burrell from Spain. A truly stellar lineup. Margaret.
Thank you.
Minister, can I introduce our researchers, and I will leave it to Professor Whitehead to begin the presentations.
Okay, I'll just see if that works. Okay, thank you, Minister, for granting me 3 minutes of your time to explain the latest results from Dimitrik, which has been evaluating natural policy experiments for their impact on health inequalities. I'll focus today on unemployment and poverty reduction policies. Well, policies to improve the employment chances of people with disabilities often have an underlying assumption that social protection has to be restricted to encourage people to gain employment. But Dimitrik has found the reverse, that policies that provide better financial security, particularly for people with disabilities and low socioeconomic status, boost their employment chances. During recession, better job security reduces some of the adverse effects of recession. For example, helping to maintain people in employment who are in vulnerable positions on the labour market, particularly those with chronic illness or disabilities and low socioeconomic status, bringing them closer to better off groups. Also, during periods when budgets are tight, there is a temptation to lower public spending, for example, by reducing healthcare and welfare budgets. But this is counterproductive. It hinders economic recovery while hitting the most vulnerable hardest. In contrast, governments that invest in social protection or health have better results overall. We estimate that smart public investments in health and social protection return up to €3 for each €1 of spending, thereby fostering economic recovery while helping to protect vulnerable groups. Finally, increasing wages of low-wage workers, such as by raising the national minimum wage, help reduce socioeconomic inequalities in health. Introducing the national minimum wage in the UK, for example, significantly improved mental health and reduced symptoms of depression for recipients versus various controls. So, our key messages, Minister, to you. First of all, some recent social welfare and labour market reforms in Europe have had unintended adverse effects, falling most heavily on the most disadvantaged and threatening to widen health inequalities. But the thing is that the differing policy responses of governments to economic downturns demonstrate that governments do have real policy options to deal with recession while protecting the worst off. And finally, changes in national policies need to be assessed for their impact on the health and well-being of different socioeconomic groups in society, and adjusted, ameliorated if they have adverse effects. We need to protect those living in vulnerable conditions, especially children, if we are to reduce health inequalities. Thank you, Minister.
No, Minister, Professor Whitehead has agreed to take some questions from you.
Okay, Professor Whitehead, you say that some social welfare and labour market reforms have had adverse effects. Could you amplify that a bit, please?
Yes, well, certainly some of the austerity packages that have produced cuts in public spending on health and social protection, they've disproportionately affected groups and areas in the most vulnerable circumstances. The cuts have been deepest in the most disadvantaged regions in the UK, for example. At the same time as debt and deficit is increasing, so it's these austerity measures have been harming the most vulnerable, but they haven't actually been improving the situation as far as the economic recovery is concerned. I think that these cuts have both direct and indirect effects. The direct effects, they're cutting effective prevention and treatment programs, and we're seeing this in particular with early childhood development and children's services, and this is a real issue in this part of the world. But the indirect effects are also a problem because the cuts increase unemployment, increase poverty and homelessness at the same time as you're cutting the social protection that would protect the health of the people suffering from unemployment and poverty, etc. And I think it's particularly acute with for children, with an increase in child poverty, increases in hospital admissions for malnutrition, and certainly in this country we've seen the growth of food banks, of the use of food banks, which is a terrible indictment of our society.
Professor Whitehead, thank you very much indeed. I'm afraid the Minister is incredibly busy, and I know that we have waiting outside Professor Siegrist from Germany. So thank you for your time,
Thank you.
Professor Siegrist.
Thank you, Minister, for giving me a few more minutes to talk about reducing health inequalities by improving work and employment conditions. The Drivers Network is a network which deals with the life course, and you can see there are 3 entry points to reduce social inequalities in health: early childhood, working conditions, and also the social protection. Now, I will focus on working and employment conditions. And the way we did research in the Drivers Project was mainly to do statistical analysis of large European-wide data sets, in addition to systematic reviews and case studies. Now, there are 2 interesting new findings I would briefly like to point your attention to. On the left side, we all know that physical work follows a social gradient. So the lower you are on the occupational position, the more you're suffering from physical work. This is probably the first study on the left side which shows across Europe that this also holds true for psychosocial health-adverse work environment, stressful work environments. And this has been shown for 2 of the internationally established models of work stress, the effort-reward imbalance model, and then in particular low control at work as the important component of the demand control model. So the higher you stand in the occupational hierarchy, the lower the level of work stress. On the right-hand side, you see we have built national means of work stress on the y-axis, and we have shown that this is associated with the intensity of establishing integration policies at the national level. This is from OECD. They have a national integration index for each country. And you can see that countries which invest much into integrating sick and vulnerable peoples into the labor market, they also have much better quality of work, much less stressful work than countries like Greece, Italy, Spain, Poland, which invest less into integration policies and which have high levels of work stress at national level. Why does this matter? It matters because work stress is associated, work stress in terms of these models is associated with elevated risks of widely prevalent chronic diseases like depression, coronary heart disease, and disability in employed populations across Europe. And the odds ratios vary between 1.3 and 2.0, depending on the outcome and on the type of study. In addition, we have shown, and others have shown, that work stress is a mediator in the relationship between socioeconomic position and health. And some additional evidence shows that low socioeconomic position moderates the effect of work stress, so the effects are much stronger in the more deprived economic groups. And this leads me to 3 policy recommendations at different levels. First of all, I think it is important to improve the monitoring of health-adverse working conditions in a comprehensive way, and also to improve the provision of occupational health services with a special focus among these lower socioeconomic groups which have the high burden of work-related disease. We need to promote health equity by tackling structural determinants of the work-related burden of disease, and in particular at the business level to improve organizational and personnel development. And finally, and I think this is in a long-term perspective most important, we should prioritize social and labor policies which strengthen sustainable employment, in particular among aging workforces, in national budgets, and particularly so in contexts of neoliberal policies and strong fiscal austerity measures. And these are the 3 most important recommendations to you.
So thank you very much indeed, Professor Siegrist, and I'm sure you'll be happy to take a few questions from the Minister.
I'm curious, have you heard of the Transatlantic Trade Investment Partnership which the European Union is currently negotiating?
I think there are interesting initiatives going on now, and there is still, at least there's some awareness also from employers' organizations as well as from the trade unions anyway.
It seems as if this partnership may well reduce occupational protection rules to the lowest common denominator compared to America and Europe. You're not aware of that?
Sure.
Okay.
This is a problem, and that's why evidence, strong evidence, is important to strengthen these kind of policies.
Okay, so the more evidence that we can get for that, the more likely we are to. Good. Thank you very much.
Thank you very much indeed, Professor Siegrist. Okay. And now, Minister, I'm delighted that we have Professor Kunst, who has come from Amsterdam, who will be presenting the SOFI project.
Minister, the Silner project has for you 3 key findings and 1 request. First key finding is that nowadays across all Europe, socioeconomic disadvantage is related to the chance that young people will start smoking. This is illustrated in this graph where you see the risk of 15-year-old boys and girls to smoke is related to the educational achievement of these boys and girls. And you see huge differences, 6 times larger odds for those with low achievements. What you see here is that inequalities in smoking arise at the moment that young people start forming their own socioeconomic career. Inequalities that will persist for the rest of their life. And inequalities that we now found across all Europe, from Finland to Portugal. And this is the problem that we would like to resolve. Our second finding relates to smoking cessation in adulthood. Here, the rates to stop smoking are higher among those with higher education, a higher occupational class. This is expressed in these rate ratios. Higher than 1 means more cessation among those with higher classes. And what's important here is that in these data from 11 European countries, we see that these inequalities increase over time. They do not diminish at the time that tobacco control policies have developed. It shows us that it would be an illusion to think that these inequalities that emerge during adolescence would reduce during adult life. No, rather they would widen, because those with high economic position, they will quit, whereas those with low education would continue. Then the third finding. What can we do about this? What has policies shown in the past? We have found that from reviews of the literature and from additional analysis that specific tobacco control measures, when they are effective among both high and low socioeconomic groups to about the same extent. That's the good news. Tobacco control is effective and brings benefits to all of them. However, we have very few examples of these policies to be more effective among lower socioeconomic groups. So they do not reduce these inequalities in smoking, with the only exception with inconsistent evidence of price. Price is essential, but it may not be enough. So that brings me to the requests that I have, my message. I think we need more policies, stronger policies, perhaps new policies. And this starts with the recognition that smoking is not a risk factor, it's not a lifestyle, but it's a commercial product. It's an addictive, a toxic product that kills people, and that each year needs new clients, lifelong consumers among young people. And I ask you, Minister, to help stop this project. First of all, I would like to initiate, support supply-side policies aimed to change product composition and presentation, aimed to reduce sales, reduce opportunities for advertisements and promotion in addition to price. And further, I would like to ask you to support equity-oriented demand-side programs, especially programs aimed to protect disadvantaged youth against smoking. And there are effective programs like the Assist program in the United Kingdom, and I ask you, help to develop, further implement and disseminate such programs across Europe.
Okay, thank you very much indeed, Professor Kunst, and I'm sure you'll be able to take a few questions from the Minister.
So the supply side interventions are very clear. We should do everything we can to make it difficult for people to access smoking and to smoke and so on. But the demand side, the data you showed suggested that one of the most important things we can do is invest more in education, invest more in broad education to raise educational attainment broadly across the whole population. Would that not be a reason to invest in schools and so on across the country to make sure that children from disadvantaged areas get better educational opportunities?
Yeah, it starts with a better education, but on the top of that, in schools, I think also more specific attention can be given to help young people also to protect themselves against smoking. I think that is an additional to the educational programs.
Okay, thank you.
Thank you very much indeed.
Thank you.
And now, Minister, we're joined by Professor Borrell from Spain.
Thank you. We have, the SOFI project have chosen an example, just an example of our project. It's an urban renewal program that was launched in Catalonia several years ago. In the project we evaluated it, and you will see now a film, or 3 minutes film, showing the evaluation.
In 2004, the regional government of Catalonia launched the Neighborhoods Law, an extensive urban regeneration program with the objective of improving physical and social conditions of the neighborhoods. The initiative was accompanied by 2 complementary programs, employment and health in neighborhoods.
La llei de barris té exactament aquest objectiu, és a dir, intervenir en aquells àmbits que necessiten d'atenció especial, aquells àmbits que són els més degradats, aquells àmbits on es concentra la major problemàtica social, però no intervenir d'una manera, diguem-ne, sectorial, no amb el tema de l'habitatge o amb el tema dels serveis, sinó en tots aquests àmbits alhora. I això són les polítiques integrades de rehabilitació urbana.
Researchers from the SOFI project, working at the Public Health Agency of Barcelona, have analyzed the effects of the physical and social improvements of the Neighborhoods Law on the well-being of neighbors. In Barcelona, 15 neighborhoods were financed by the Neighborhoods Law, the majority of them being deprived areas in Barcelona. Among these, the first 5 that had completed all projects were selected for 2 studies, which we present here. The first study analyzed the perception of neighbors towards changes in their neighborhood, and results showed that the majority of the Neighborhoods Law project had positive and important effects on their health.
Una de las cosas que se pelearon mucho para que se hicieran fueron los ascensores de la calle Alcántara. Esto ha sido estupendo, porque si no, para poder subir a la montaña caminando, imposible.
The second study analyzed data from the Barcelona Health Survey with a sample of neighbors representative of the population to learn about the changes in 2 health indicators. The changes produced in the neighborhood that had been intervened by the Neighborhoods Law were compared to the neighborhoods that were not intervened but had similar socioeconomic conditions. Here, we see how in 2011, self-rated health improved in respects to 2006 in the intervened neighborhoods, while no changes were seen in the comparison neighborhoods. Mental health status also improved in women in the intervened neighborhoods, while in men, the intervention appeared to prevent the worsening mental health that was visible in the comparison neighborhoods. We have also observed that the improvements in health were more important in the more deprived populations. This research has helped show how urban renewal policies can improve the health of the population. In the city of Barcelona, it appears that the Neighborhoods Law has improved health and reduced health inequalities.
I'm sure you'll be happy to answer some questions from the Minister.
Do you know how much money was spent on these environmental improvements?
Yes, around between 10 and 15 million euros.
Okay. And has any economic evaluation been done about the benefits in economic terms of that spend?
There are groups that are studying this, not us, because we are studying just the health effects. But there are other groups that are studying other effects of the neighborhoods law. Okay. The problem is that this law was stopped just when the government changed. We had a change of government. We have a right wing now. We had a left wing before. That government was who implemented the law, and now the law has been stopped.
Thank you
Politicians.
Thank you very much, Steve. And I wonder, Minister, if you have any final reflections
Yes.
on the presentations that you've heard.
Yes, I have. What we should do is all of these things. It seems to me that, okay, on the one hand, we've got a conventional project that's looked at reducing risk through stopping smoking, but we know that smoking is associated with lack of a sense of control and mental health issues and so on. And the other projects are all to do with improving the environment, improving the probability of getting employment, and once in employment, reducing the risk that employment will damage health. It seems to me that all of these, with perhaps the jury's out on the last one, but all of them will be cost effective. All of them will reduce long-term costs for the health service through sensible investment up front. So we should do all of them, and if any of my fellow politicians complain that it's too expensive, then I think you should just get the Finance Minister on the phone and we'll tell him to increase income tax for those earning more than €100,000 a year to 50%, and those earning more than €200,000 a year, we should increase it to 90%, except if they work in banks where we should make it 100%. Okay? And by redistributing income and redistributing wealth in that way, we should be able to free up money to broadly and significantly improve quality of life and outcome of life, and give people the opportunity to, which I certainly believe Scotland should be aiming to, increase the likelihood that every citizen in this country should be able to achieve his full human potential. And we can only do that if we don't relentlessly pursue income inequality in the population. So get me the Finance Minister on the phone, and then we'll go to the public.
Minister, I will immediately go and find the Finance Minister, and we will tell the Prime Minister that she will have, or the First Minister, she will have to wait. Thank you all very much to our speakers, but I also have a few other people to thank. And I'd like to thank Carolyn Costans from EuroHealthNet for pulling all of this together. I would also like to thank Johan Mackenbach, who actually played a role behind the scenes in pulling together the project. And of course, our speakers, but we wouldn't have been able to, or they couldn't have had anything to present if it hadn't been for DG Research in funding this work, and I know Barbara Kirstens is in the audience somewhere, so thank you to DG Research for their continued support for public health research, and of course you will now go back and tell your colleagues what remarkable results are being provided and why we need to have even more support for it. And thank you to all of you for staying on. Thank you very much indeed.